સવાર છે. ગુડ મોર્નિંગ. યસ. સો મને લાગે છે કે બધા આપણે જાગ્યા નથી, એટલે એક વખત આપણે બધા હાથ ઉપર કરીએ. યસ. સ્ટ્રેચ યોરસેલ્ફ. બરાબર. સો ટુડે I thank AOS અને Farmed for giving me this opportunity to talk about bone muscle crosstalk. સો જ્યારે બી આપણે ક્યાંય બી વાત કરતા હોઈએ છીએ તો બોન્સની વાત થતી હોય, બોન્સના ડિઝીઝની વાત થતી હોય, પણ એઝ ઓર્થોપેડિક સર્જન્સ મસલ્સ પણ આપણા માટે એટલા જ ઇમ્પોર્ટન્ટ છે. સો સ્ટ્રોંગ બોન્સ એન્ડ વીક મસલ્સ ઇટ્સ અ કોમન પ્રોબ્લેમ. ઓકે. અને એ બધું ઘણી બધી ઇશ્યુઝને એ બધું ક્રિએટ કરતું હોય છે. જેમ કે બોન રિલેટેડ પ્રોબ્લેમ્સ હોય તો દેટ વી સીમ ટુ મેનેજ પ્રોપરલી. પણ જ્યારે બી સાર્કોપેનિયા છે વિચ ઇઝ ઇન્ક્રીઝિંગલી પ્રિવેલન્ટ એન્ડ ઇટ ઓલ્સો ઇફેક્ટ્સ ધ આઉટકમ ઓફ અવર બોન મેનેજમેન્ટ. જ્યારે અમે સિવિલમાં ભણતા ને તો એનેસ્થેટિસ્ટ એવું કહેતા કે ઓર્થોપેડિક સર્જન મૂકે ચેકો એટલે સીધું બોન આવી જાય. બરાબર. વચ્ચે મસલ વસલ આપણા માટે કદાચ ત્યારે ઇમ્પોર્ટન્ટ નહોતું, પણ નાઉ ઇટ ઇઝ ઇન્ક્રીઝિંગલી ઇમ્પોર્ટન્ટ. So, sarcopenia is frequently underdiagnosed, but it affects in a lot of way, like decreases the quality of life, increases the functional impairment, increases the risk of disability, risk of falls and fracture, and ultimately causes depression and anxiety. What are the conditions that are related with sarcopenia? ઘણી બધી orthopedic conditions છે which are also related with sarcopenia, like osteoarthritis. Iatrogenic કહીએ તો orthopedic surgeries પછી because of prolonged bed rest, it also leads to sarcopenia. Rheumatoid arthritis, or for that case any inflammatory arthritis, spinal disorders are general conditions which are associated with sarcopenia. Risk factors for muscle weakness are nutritional, physical inactivity, iatrogenic and underlying medical conditions. Muscle weakness ની વાત કરીએ તો what is the pathophysiology for muscle weakness? So in a normal muscle turnover scenario, there is always some protein breakdown and some protein formation. But ultimately the net balance is towards protein formation. So there is always an increased protein formation which increases muscle protein synthesis and increases the number and size of the muscle fiber. But when there is muscle degeneration, the protein breakdown increases compared to the protein synthesis, which leads to decreased muscle formation and decrease in the number and size of the muscle fibers. If we talk about the pathways for muscle synthesis, there are three pathways which are one or the other way indirectly interconnected to one another. One is the mTOR pathway, next is the IGF-1 and GH pathway, and third is PI3K AKT pathway. And all these three pathways in one way or the other increases the muscle protein synthesis and the muscle growth. While when we talk about protein breakdown, then there are two pathways, that is ubiquitin proteasome system and the FOXO genes pathway, which ultimately increases the muscle protein breakdown and increases muscle loss and muscle weakness. What changes occur during muscle weakness is there is chronic inflammation, which then decreases the blood flow and the flow of amino acids to the muscles, decreases the neuronal number and ACH release, and ultimately increases the lactic acid accumulation. So we all know that improved muscle strength will lead to faster fracture healing when we talk about orthopedic output or orthopedic results, better recovery, higher functional independence scores, lower pain scores, and shorter hospital stays. So it comes to a point that properly detecting and managing muscle weakness is of paramount importance to decrease the risk of further fractures and also to improve the fracture healing and patient's quality of life. Again, muscle around the joints helps in recovery in all these ways. It increases the joint mobility, increases the faster overall recovery, reduces pain, improves the blood circulation. Ultimately, it promotes greater patient independence and boosts his or her mental health and confidence. So, આ કદાચ આપણે બધાએ જોયું હશે કે if the patient is fit and fine, if the patient is strong, our output or our results in terms of our surgery or our management is far better in such patients, and they are also happy with us or with the results rather than the patients who are weak. There are certain tests which you can do in your OPD or in your IPD setup to test for muscle assessment and to diagnose sarcopenia. So one is the gait speed, chalwani speed. So if it is less than 0.8 meter per second in males and females, then you should think about sarcopenia. The grip strength, there are instruments available to assess the grip strength. In males, if it is less than 27.5 kg, and in females, if it is less than 18 kg, then you should suspect sarcopenia. 5 CST, that is chair standing test. Chair પરથી ઊભા થાઓ, બેસો, 5 વખત કરવાનું. If the time is more than 12 seconds in male and female, then you should think of sarcopenia. And the calf circumference, if it is less than 34 in males and 33 in females, then there are chances the patient is suffering from sarcopenia. What are the patient groups which you should assess or which are in higher risk of sarcopenia are people or patient above age of 60 years, all the patients with chronic morbidities, chronic inflammation, and risk factors like prolonged immobility, critical illness, and malnutrition. Most important thing, what are the challenges in the treatment? So there is no any specific drug treatment available for sarcopenia. There is lack of awareness in the patients, in the doctors. Patient compliance is very low, and physician perception and therapeutic nihilism are there. In management strategies, it's a multimodal approach. No single approach will help you to get the output that you want. So there are pharmacological treatment, nutritional treatment, physical exercise or physiotherapy, and psychosocial support is also important. When we talk about nutrition, there are two things. One is muscle non-specific nutrition, which includes all the proteins, vitamins, minerals, vitamin B, vitamin B12, and micronutrients, which help in overall general ability and general well-being of the patient. And when we talk about muscle-specific things, then there are three compounds. One is HMB, carnosine, and leucine. So what does HMB do? It increases the protein synthesis, inhibits the protein breakdown, and has an antioxidant and glycogen content increasing effect on the muscles. L-carnosine will regulate the muscle pH, will regulate the lactic acid accumulation, promotes the sensitivity of muscle fiber to calcium, increases the proliferation of satellite cells, decreases the muscle breakdown by decreasing the UPS and the FOXO genes activity, and regulates the muscle excitation and contraction coupling. While in case of astaxanthin, it will induce the satellite cell proliferation, decreases the inflammatory mediators, stimulates mTOR pathway, which is a protein synthesis pathway, preserves glycogen stores. It also decreases the UPS and FOXO gene activity, decreasing the muscle breakdown, and mitigates the rise in lactate and hydrogen ions. So combination of all these three things will improve the muscle mass, strength, performance endurance, recovery, and mobility, and reduces the muscle pain and fatigue. So PharMed has come out with a drug which is known as Improsin, which combines all these three things, that is the calcium HMB, L-carnosine, and astaxanthin, and it helps to enhance the muscle regeneration and prevent the muscle breakdown, ultimately building strength, endurance, and hastens recovery. So I think this should be an added prescription to all our other prescriptions in case of patients who are suffering from sarcopenia. So I thank you all for giving your valuable time, and thank you for listening to me. Thank you, AOS, and thank you, PharMed.